On behalf of SIMSOG, I extend a warm welcome to the day 2 of What Went Wrong, a case-based workshop series on ethics and medical legal perspectives of OBGYN. So, Society of Indian Medical Students of Obstetrics and Gynecology is committed to fostering interest in OBGYN through advocacy, academic discussions, and leadership opportunities. And now, we would like to begin with the introduction of this event. So, What Went Wrong is a 3-day case-based workshop series which explores the ethical, medico-legal, and the clinical dilemmas encountered in reproductive healthcare. So as we set stage for today's workshop, it is important to highlight the core of this session, which is the respectful maternity care and obstetric violence, and the medical negligence, documentation and confidentiality, and legal aspects of MTP and POCSO Act. So we now move on to the main segment of today's workshop, which is the case-based discussion. So the participants will be divided into 3 groups, with each group receiving a different case scenario for discussion. You will have 10 minutes to deliberate within your group and analyze the ethical and clinical dimensions and prepare your insights based on these cases. So after the group discussions, each team will present their findings to our speakers, highlighting the ethical issues, dilemmas, and potential resolutions which are identified within the breakout discussions. So following these presentations, our distinguished speakers will share their insights and reflections on each case, offering both clinical and ethical perspectives that are more related to the evolving medical ethics. So after which each case-based discussion, including the group deliberation, presentation, and the expert commentary, will last about 45 minutes in total. So if you have any queries regarding the event format or the flow of the session, please feel free to reach to us. It is more similar to that of yesterday's case-based discussion, but today's sessions will be of 45 minutes. So we will be happy to clarify them if you have any doubts before we proceed on with the group discussions. Okay.
Good evening. Yes, hi, I am Karuna. So because we have a 45-minute limit this time, 45 minute per session this time, we will be keeping the breakout rooms for 10 minutes. You will be able to see a 30-second timer. So that is your indication to sort of wrap things up. We understand that yesterday there was a bit of an issue with the breakout rooms and the timers, but because we're working at a tighter schedule, please use that 30-second timer as your indication to wrap things up and engage in discussion. Thank you.
I hope every breakout room had their own discussions on their cases. And now it is my privilege to introduce our distinguished speaker, Dr. Kaveri Mayra, whose work bridges research, practice, and policy in maternal and reproductive health. She brings a unique perspective on the intersection of evidence-based care and patient-centered advocacy, highlighting voices of women and marginalized communities. Her insights continue to inspire innovations in nursing, midwifery, and global health initiatives worldwide. So we are truly honored to have you with us today, ma'am, and we look forward for your insights on this important topic. And now we invite the participants in breakout room 1 to present your findings on your assigned case. Dr. Harish, you were in breakout room, I guess, like breakout room 1.
Yes, it was a case in Uttar Pradesh, I guess, where in Balia district or somewhere, pregnant women who was an active labor was left at the community health center at around 2:30 a.m. and there were no paramedical team or emergency medical officers or nurses to receive the patient, and this was recorded by the uh, bystanders of the patient, and the video went viral, and everybody in that community health center were transferred. And that is the summary of that case.
Yeah, the participants in breakout room 2 and 3 can also present their cases now.
I think Samya was in breakout room 2 with us. So would you like to share your findings about the case?
Yeah, so in our case, since I feel like the first point that has to be noted was though she was brought in pain, in labor pain, she was made to wait until 2 a.m. for delivery. I feel like that itself is wrong because in labor, you're supposed to act quickly, and she was just told to just wait without any sort of assistance. And the number one thing that when you learn in medicine is to like do no harm, and the nurse itself violating that and verbally and physically abusing them is just inexcusable. And yeah, I feel like a person in labor is just really vulnerable, and calling them words like uncivilized is just, I think it's just ethically wrong and morally incorrect as well. And it calls for reforms in terms of how patients in labor in general treated in the hospital setting.
Um, is there anyone like? Is there any breakout room where the case hasn't been presented until now? The breakout room 3 where
We could either have people from room 3 talk, or we could continue discussing case 1, and then eventually, if people from room 3 want to talk, we can continue. So let's do case 1. Everybody, the case will be presented, and everybody, you can share your thoughts, and then ma'am will talk as well.
ma'am, as the cases have been presented, you can proceed on with your insights based on these cases, ma'am.
Sorry, is it my turn to speak?
Yes, ma'am. Yes.
Okay. It's slightly unclear to me what the format is. I was expecting people will be speaking on these particular discussion questions. Do you want me to give you my perspective of these questions?
Of
Or
these
can I
cases.
how about I just lead a discussion, and I will also get to understand what people feel about it, because I think the team's perspective is not come out yet. Is that okay? I'm happy
Yes,
to
ma'am.
facilitate. Yeah. Okay.
That's what we want. Yeah.
All right. To start with, I have to say that there are a few things that I have read in these news clippings that have also made me deeply uncomfortable. I myself come from a midwifery and nursing background, and I feel like I have seen and read so many instances of obstetric violence that I often feel there's nothing there that can shock me anymore. But I have to say, the case that was read out about I think there was a stillborn being passed on in a dirty plastic bag or something. Um, yeah, infant's body was given in an unwashed polythene bag to the parents. I think that made me deeply uncomfortable. I'm not sure if everyone has read all the three scenarios, but I see that the questions in the breakout rooms are different, even though they are sort of valid for any kind of scenario that are here. But I think for the sake of discussion, it's helpful that we can all participate in all of these questions. Let's not. Yesterday, I came in to see how these sessions work, and I saw a few long, awkward moments of silence. Let's not have that. I'm also here to learn, and please do have a perspective from that angle. I'm not trying to teach. I'm just here to share what I have seen in my career, because I think I have been doing just this for the last 2 decades. All right. So you have read the scenarios. I want to understand, first of all, what do you feel when you hear cases like these? I mean, they're definitely very triggering. And regardless of who is engaging in this kind of obstetric violence, but can I have like some initial thoughts on what you feel when you come across something like this?
Can I say?
Sorry, is there a way of raising hands here so I can just like, yeah, Ananya.
So like so these cases, so like although so like they come up and like they're peppered across the year, so they also like lead us to come from where they're coming from. Is that a rural background? Is that like a tier two, tier three cities? They also so they also show us like the labs in the emergency care, the labs in our medical care, the labs in the team. If they're not so like we all if we signed up for like community, like we want to work for the community, that's why we join to become doctors, and like that's where most of the things are in these cases are lacking, which is like a drive to serve the community.
Just tell me what your feeling is when you see something like this. I just want to know people's feelings at this point.
Ma'am, what I feel is that it's highly unhuman because you're slapping a woman just because she would cry in pain. I mean, it's pretty normal for a pregnant woman to cry while delivering a child, and to put her child into a polythene bag. That's a human, okay? And just to put it in and just throw it and to compensate that thing with money, you can't just compensate the loss you have faced with money.
There is no compensation of something like this. I completely agree. So you said inhuman. There is no compensation that can be fair for a scenario like this. Any other hands? I'm seeing Samya. How did that make you feel? Just your perspective. Whether it's right or wrong, we'll see later. But how does that make you feel as a human? You read this. How does that make you feel?
First of all, as a girl myself, it evokes a very strong anger. And my take on this is that these issues are very often linked to systemic issues and injustices. Like, for example, as Brenda said, that about uh, coming from a more rural background or your education status, these things also impact how you get treated, even in a healthcare setting. And while it's not something that should be happening, it's the truth. And how especially and it's very common, and the healthcare laws in India should be more strongly imposed to prevent these types of situations.
Thank you, Samya. I think next we have Gitanjali. Also, I'm insisting that you just share how that makes you feel. What should happen about it, we will get to that. But right now, just tell me what that makes you feel.
Yes,
Gitanjali.
ma'am. Honestly, I think a huge part of being in healthcare as a healthcare professional and a healthcare worker is empathy. They constantly stress on having empathy and being empathetic, feeling for the patient, stepping into their shoes. And I think these healthcare workers have failed in that aspect big time, which is very disheartening to say the least. And I cannot understate how important the other aspects that the other participants highlighted as well.
Thank you, Gitanjali. I think Bindu is next. Oh, sorry. Is it Harish? I think Harish is next.
Yes, like when I read about this now, like I'm not really surprised because I'm a post intern and I've seen such things happening in OBG, especially the labor ward, like on a daily basis. So to me, the very first thing is like I'm not really surprised, but having questioned about this so many times again and again, I feel that there is an inherent patriarchy within the healthcare system, within the society, that even women tend to, you know, go on and perform acts like these on vulnerable other women. And that is what makes me so, it makes me question a lot of things about human nature and other things, like why a person would behave like this towards another person who is in pain and other things.
Thank you. Bindu? You're muted, Bindu. Oh, Bindu left the meeting. Are there any more hands to respond to this particular question? All right, I'm just noting down some keywords here, right? And you have some of these questions here. I am taking note and I'm trying to stay on track on those questions as well. Oh, Bindu is back. Welcome back, Bindu. Can you
Thank
hear
you.
us?
Yeah, I
We are
can hear
waiting
you.
for your
Sorry.
reflection.
Yeah, like, uh, pertaining to, should I talk pertaining to case 1 or case 3? Because the case has changed.
Any case, in fact, if it is something that you have seen yourself, I'm just trying to understand what, as a medical student, your initial reaction is when you see something so abusive, so disrespectful, and outright violence.
Uh,
How
yes,
does
ma'am.
that make
It's actually very inhuman, like when they treat like that. And yes, it doesn't fall in the ethical what we have on the 4 pillars. But I guess it's not only about us, like as a doctor or medical student. It comes to an entire teamwork, knowledge and education about how we are supposed to go ahead. And yes, all of us play an equal role in this, so it becomes everyone's equal responsibility to take part in this. So I don't think only one of us can make the change in this. It's a complete teamwork.
Thank you, Bindu. Um, I have to share that I came across obstetric violence without knowing the terminology like we do now. It's nice to hear that students are talking about these particular terms. I completed my nursing graduation in 2008, and to me, everything was quite theoretically correct and rosy in our textbooks. But then I was quite shocked when I started seeing all forms of disrespect and abuse and violence, in particularly labor rooms. Um, and I think the biggest shock to me was not that I had not seen patients being disrespected or abused in certain ways in other wards that I had practiced in, but somehow it was most shocking to me to see the scenario in the labor room, because the women who were there, the women who were in labor, the women giving birth were not patients. These are people who have come for some assistance on a particular event of life. And it just felt very, very odd to also see how normalized this particular form of abuse was. Um, the scenarios where you saw someone being slapped, I used to see someone being slapped almost every day and multiple times, because if you have been inside these labor rooms, you'll see there are labor tables lying next to each other, there is no privacy. And I was quite stunned to see that the women who were being beaten up, who were being verbally abused, who were being called names like you have heard here, someone was being called uncivilized. It just, I couldn't understand how it was so normalized, and that life went on like a regular day at work. And because most of it I was seeing at tertiary level hospitals, so these are very crowded, very busy spaces, right? It wasn't, it just went unnoticed by other nurses or other doctors. Or I think it was us students who were the most shocked and just like staring and watching this absolute environment full of abuse unfolding around us. And I think it felt like we need to do something, because we were taught to be advocates for these women, that we have to protect them and not just provide clinical care. But then also somewhere we felt pressurized that we have to get conditioned. So I think my next question is also someone who I remember someone said that we start with do no harm, right? And it's for all of us healthcare providers. Um, can someone, I mean, if you can shed some light on what happens in the process. We do start with do no harm, and all these nurses, all these doctors, and all the other, it's not just clinical care providers, by the way. We see non-clinical care providers as well. We'll see sweepers, we'll see cleaners, we'll see group D members. Anyone can come and abuse and leave, which is also quite shocking to me. um, can you tell me why people who have started with do no harm, I mean, at some point in their career, reach a point where they start abusing um, women who are in such a vulnerable phase?
Can I say?
Go ahead, Brinda.
I guess it's or not at all justified. Even if they are even if they are the health professional, it's not at all justified. But if they're doing that, I think it's for the workload they're having, the amount of patients they are seeing each day. So they start treating patients like a commodity, and it's not at all justified. It's very wrong. That's what I feel.
I completely agree about none of this is justified. But they all started like us, right? They were all students. They probably stood in the same similar kind of obstetric environments, and they probably saw that kind of abuse. And they also probably wondered, ये क्या हो रहा है? ऐसे कैसे आप किसी को मार के चले जा सकते हो? Right? So I'm just trying to understand what went wrong. Workload is an excellent answer. I see Bindu's hand.
Oh, it's not like it's not only about the workload. Like, yeah, we all start with some kind of a patience. Sometimes as we go ahead, the patients test our patience a lot. So through the process and experience, people lose their calm and how to talk with them. And some one more reason why uh, such conditions happen, like the polythene bag, maybe what the funding is coming for the hospital to bring the equipments to do the process may not be being used properly, and we can't tell the hospital doctors or nurses to get it from their money, because there is separate administration who are responsible for it. So it's even their fault at that point. But I'm not trying to validate by telling this that a loss of patience, but yeah, it happens. So I guess so about that.
Thank you. I see Tanya's hand.
Oh, yes, ma'am. So, in my opinion, I believe that while for a doctor over time, I feel like it feels like to them it's like any other day at work where a patient delivers. But it's important to remember that for the patient, this might even be their first time experiencing something like this, and it's just a huge wave of emotions going through them. So over time, since a doctor might have seen so many cases like this, they know how the outcome's going to turn out. They know that the delivery might be okay, or the child might be okay, but the patient's still worried about it because it's their first time going through it. So I feel like that the over time, the doctor just decides that as long as the patient and the child is physically all right after the birth, it was okay. But the emotional part of it slowly begins wearing out over time, and they forget that medicine as whole is holistic, and it includes both physically, emotionally. The patient should be okay. But I feel like just over time, even they begin numbing to it because they feel like to continue going on, they cannot get deeply attached to each patient. So they just start suppressing their own emotions as well to just keep going the process.
A lot of really important keywords in your response, Tanya. Harish.
But I believe as Indian students, we have, we usually do not question a lot, especially to our seniors or our professors. So what we see, we think that, okay, this is correct. This is the right way to do it. I see my professor doing it. I feel like, okay, so this is how it is done and this is correct. And that is how I feel like junior doctors also joined the, that way of shouting at and, physically abusing and all that, because they feel that is the right way to do it. That is the main reason, I guess.
So, unless anyone else has, I don't see any other hands up. So, from the last point of what Harish just said, is it the one person who say slapped or hit? Is it when we think about whose fault, or when we talk about accountability? Do you think it is that one care provider's fault, or do you think it's a team behavior? Brinda, are you responding to this question?
Yes, ma'am.
Go
Ma'am,
ahead.
I think it's definitely the fault of the person who did that. And apart from that, it's the fault of the management because they didn't look after look into the thing that how the person who had they have appointed is treating the patient. And even if she was good while she was appointed, they have to keep on seeing that if that person is okay, if she is not having so much workload, as I said before. I think that all things has to be considered, and if she needs a sort of counseling, so I think that's pretty it. Pretty much it.
I think I saw Harish's hand as well.
Yes, I feel like, apart from the individual, apart from the healthcare providing team, the entire society is to be blamed for such things. Because, one excuse we give is like the workload is heavy, it is very irritating to see patient after patient and delivery after delivery. If we see the same night in an emergency, I mean, in a trauma unit, we receive patient after patient uh, with alcohol consumption under the influence of the alcohol. They come after an RTA, but never do we hear instances like they are being slapped or they are being physically abused or they are being verbally abused. So I feel that it comes down to violence against women is not taken very seriously in our society, and that is why this has been prevailing for a very long time. But it has to improve, but it is improving as well, but we need to work more on that.
So you are saying this is a gender-based violence.
Of
And
course.
I think the next question, because I also heard someone mention patriarchy
Yes, it
earlier.
was me. Yeah, it was me.
So may I? Okay, Tanya, you go first, and then I'll add my next point.
So for me, I just believe that while the common notion is that it's just for children who are just growing up are considered to be the product of their environment, but I feel like throughout our life, the environment that we are in always plays a role on our behavior. It's not just us kids growing up. So we can just take any example as a person who's just there in a professional setting, or if they're just at home, the behavior does change. So even in this situation, I feel like for the person to feel like it was okay to do that, it just does not come if the environment that they are in did not allow that. Like anybody wouldn't just do that unless they felt like yeah, I feel like it just depends on the environment that you're in. Like it definitely like gives you the sort of it shapes the boundaries, and especially in a workforce kind of environment, like there you do not tend to act outside those boundaries. So for a person to act like this, it definitely makes you question like what was allowed in that hospital or that healthcare system for
So
something like that.
simply put, not to cut you off, also please utilize the chat section for people who don't feel comfortable speaking up. It's absolutely fine if you just put in your thoughts in the chat, and it can be as abrupt and here and there as possible. But because I've been told this is a properly interactive session, so that's why I'm really hoping that more people will also join in. Um, so next question, I think, is mostly where you have to say a yes or no, and it's fine if you can put it in the chat. If men gave birth, do you think obstetric violence will exist?
I believe no.
I believe yes.
Okay. Keep going with the yeses and nos. Please
Okay,
put
then
it.
I'll say.
I think it's the in-call messages is very empty. Or is it just me? Am I not seeing? Or nobody has written anything? Can someone type something so I know I'm seeing the chat as everyone else is seeing?
So far, there's no other text in the chat now.
Okay, no, people are typing. Okay, while people are responding to this question, I also want to say I have added a link which throughout this discussion, I will keep adding links to papers that I have written, that other colleagues have written, that will help you understand some of these things better. So this paper is something that I wrote a few years ago. It's called Why do healthcare providers disrespect and abuse women during childbirth? It basically answers a lot of these questions that you have already. Um, and I'm really interested in seeing. Okay, so someone has said the conversation about men had periods, then pads will be free. I have also heard that if men got pregnant and didn't want babies, abortions will be done in like ATMs and booths. That is one line of conversation, but I'm interested in hearing from Brinda, who said if men gave birth,
Yeah,
obstetric violence would be less.
for the thing that pads would be free if men had periods, I'll definitely agree to it. And that's definitely a thing. And what was the other one that you said? Uh,
No, we are not focused on pads. We are not focused on menstruation. We'll only talk about
Yeah,
obstetric
so
violence.
that all I really agree to those. But in this case, where the woman is abused, I have heard it mostly the health worker is a woman who's abusing her. It's not a man who's abusing her. It's not a man who's slapping her. It's mostly it's the other, it's a female health worker who's slapping her. I think if men could have given birth, uh, that the same situation could have happened. Like other health worker who was a man could have hit him. That's what I feel.
And you're basing that on the fact that most primary healthcare providers who are assisting childbirth and are providing the care around it are women, right? That was your point.
Yeah, sort of. Like, it's not that women get hit by men in the labor room. It's almost. What I have heard is that mostly they are women who are hit by men. But thing is that I'm a first year student. I'm just going through my foundation course, so I'm not really aware of what's really going on. So I'm open to corrections as well.
No, it's not about correcting, but just a couple of points. I think you are right that there are a lot of women who are abusing women in obstetric settings, but I have seen plenty of men abusing women as well, and often in the most extreme manners. That includes a lot of pinching with artery forceps and saying something that is deeply inappropriate, conducting vaginal examinations without changing gloves. Those are, violent as well.
Okay, that's really a matter of concern. That's really, really wrong.
So yes, so the other thing why you are saying women will also still continue to abuse, I think, is because the answer lies in that fact that somebody said patriarchy, right? And patriarchy is not just forwarded it's not a parcel being passed on between men. We are all products of patriarchy,
Yeah.
right? So we are all conditioned in a particular kind of society, in a particular kind of culture, where even though at times we as women are at a disadvantage, but that's how we know to function. We do not know any other way of being. So we get tuned with all the content being repeated around us, and we repeat what is being done. Also, we want to be a part of these teams, right? Earlier, I was saying, do you think the person is at fault or the entire team is? I'll share a case that I saw from Delhi. Um, this is a report that came out a few years ago, and I forgot which team. I think Nazdik was the name of this NGO that wrote this report, and they found there was this urban health clinic where almost every woman who was giving birth sort of returned with a PPIUCD. Everybody knows what a PPIUCD is? Postpartum intrauterine contraceptive device. And this was being inserted without the consent of the women, even though, and some people, when they came back for not being able to get pregnant, they found out. And this was a very normalized form of abuse that went on. So, what I'm trying to present is a case where there wasn't one person, wasn't one healthcare provider who was engaging in a particular form of violence, but it was a culture of that team. All the doctors who were at a particular shift, all the nurses who were at a particular shift, it is just something that they did. There's Tanya here. Would you like to come in now?
Yes, ma'am. Ma'am, like I just wanted to like mention at that point about like how earlier you had mentioned that childbirth is considered to be an event, like how a person requires assistance. So about the question regarding obstetric violence against men, I feel like even they would be subjected to violence because of the same notion about them considering that it's an event and not exactly like any other patient coming in. And also about the IUCD, about the PPIUCD. Even during my first year, I heard about that. And I heard about it that apparently the interns or the residents who were there, they had, because of the government's planning where they were told to like, in light of like for population control and like increase the use of contraceptives. They had like this fixed amount of patients who they had to convince to get a contraceptive done. And that was some sort of like, it had to be a goal, like almost as if it's some sort of banking or insurance company trying to reach an amount of goals. So at that point, right after the woman gave birth, like before they were still going through the heightened the experience, and they, without even properly explaining them what was going to happen, they just gave them an IUD. So that's something that even I heard.
So now that we have talked about people, now that we have talked about how teams perform, is there any sense of accountability on the health systems? Anyone on what the health system's responsibility should be? And do you
I
think
think,
that
can I
health
answer?
systems play a role in enabling this kind of obstetric violence? Vrinda, you were saying.
Yeah. So I think first of all, they should always, look after, evaluate that what their staffs are doing and all of it, like how they are with their patients and all of it. And the other thing is that all of us know that the number of beds in our country is very less as compared to the number of patients. So obviously that's the thing that the healthcare system has to take care of. Yeah, I think
Thank
that's
you.
pretty much it.
That's definitely a very important point. I think one of the things, going back on how we land at a point where we are able to abuse, when all of us started from do no harm, and during the process we sort of lose that compassion and we somehow fail to empathize. um, Someone also mentioned about workload being a point. I think it's very important that um, the human resources for health, the HRH ratios about clinical and non-clinical healthcare providers needs to be maintained. Um, Otherwise, you're just creating a sort of a policy environment, and you're also creating a sort of birthing environment where giving birth with dignity and respect becomes very tricky, because even if a healthcare provider, let's say, spoke very respectfully, didn't call the person a patient because they are not, didn't use words like delivery because they are not delivering, they are giving birth, and did everything right, but still, because of the workload, they might not be able to give them as much time in providing care as is needed. So some of the things like giving privacy, um, and giving their assistance and spending as much time as they need to with the people giving birth might not be possible. So neglect often in this case is not intentional, but because they just don't have enough healthcare providers who can divide the workload. So that is an important point. What else? How else does health system insensitively enable obstetric violence? Bindu.
Ma'am, a health system, like when in a team, the senior doctor, in the team who is the senior should make sure to check the next to that they are doing it like they're not doing the mistake what we are talking about, and that's only, I think that's the key role which can play to correct this thing. And yeah, if this continues for a longer period of time in the upcoming generations, maybe this can be the change. I think this is the only change which can be brought from within the healthcare system, like making a checkpoint of how the behavior is of the person.
So when I'm talking about health system, I'm mainly talking about people who are absolutely most of the times not even providing care themselves. These are people who are, say, IAS officers who have no medical training whatsoever, qualification whatsoever. These are politicians who are furthering policies that they don't have a background in, but they have had consultants, for example.
Yes, ma'am. I think that's completely right that they do have like, yes, they are responsible for it, because most of the times we see that in case of private setups, they are able to provide a proper care, like in majority of the times. But yeah, they have to like, there are rules and regulations. It's not like there aren't. They are just textbook Korean, like they're only in the textbooks. We don't see them in reality. So I guess, like, making sure that the resources are available and put it in the right place where it should be, where it is needed, is also one of the main thing that has to be done.
So I will
Ma'am,
go back
ma'am,
to what, yeah.
yes, ma'am. We are really sorry to intervene now. We have our next speaker, who is Miss Nanditta Batra.
Mhm. And how much time do I have left?
Ma'am, actually, the session is was till 6:15, ma'am. Like, we have the next cases to be presented now.
Okay, awesome. Can I ask one final question before we end this?
Yes, ma'am.
Yes,
Sure.
ma'am. We can take 5 minutes.
Okay,
Thank you.
perfect. Thank you so much. Okay, and so basically we were talking about health systems, right? So what I want to understand is when something like this happens, I mean, people have lost their compassion. People are, I mean, the empathy is being corroded. There is no way people can say process their emotion when they are seeing birth and death and stillbirths are happening and there is loss which is not being processed by doctors and nurses. So for whatever reason we are losing our empathy and it's becoming very difficult to show compassion on a daily basis, right? So what should be done as, let's say, I don't want to say corrective measures, but what will ensure respectful care when something like this happens? What do you think can be done that will address obstetric violence and that will ensure respectful care? Oh, okay. So I have you as SIMSOG organization. I don't know your name, but please go ahead.
Good evening, ma'am. I'm Karuna. I am part of the organizing team itself. I think as we spoke about how these things usually happen at a larger center because there's so much people and there's so much workload. Maybe if we could have it at a more, basically like have a smaller center and have a lot of smaller centers so that you have certain healthcare professionals catering for a certain smaller population.
Mm-hmm.
I feel like that could, but again, another thing that comes in is how are we regulating this? Because it becomes difficult when you have so many people and so many smaller pockets in terms of regulation.
I am seeing
Um,
some of these corrective measures here that have been taken. Like they have fired the nurse, and there is a compensation that is being given. Do you think these kind of things work, like reprimanding, and in this particular way works? I see Harish has a hand up. Harish, you're muted.
No, am I audible now?
Yeah.
Now, what do we see in these larger centers is only mostly complicated cases of pregnancy. So anyway, they will have to refer a large number of complicated cases to a larger center. So I think this comes down to individual change. Like nothing can, India spending just 1% of its GDP on healthcare. So we throw in more money. Everything, whatever we do, it comes down to individual responsibility. When only a healthcare team and the patient is available, no level of scrutiny, no level of transferring and all can work. It comes to how I, as a human, will treat that another human. So that's what I believe will change this.
Okay, so a few points. First of all, I have added two more papers in the chat. One talks about embodied experience of obstetric violence. And when you read that, you will see there are scenarios where women are being abused, not just in tertiary level care, but at primary and secondary levels of care as well. And there is the other paper which talks about why this happens from women's perspective as they experience it. I want to go back to Karuna's point, though, that in busier and bigger hospitals this happens. While there is some truth to that, but like I said, obstetric violence happens at PHCs, at CHCs, at district hospitals, at multi-specialty, super specialty hospitals, in public and in private hospitals at all these levels. But having said that, it is right that what I have seen and what research suggests is as you go higher up in the ladder of caregiving, violence increases. So you may see that there is verbal abuse, but of more subtle forms in a primary healthcare center. But that's more to do with because the healthcare provider is providing care to a smaller population where they often know the people, they are not as abusive. But when you go higher up, the wards get busier. There is more complicated cases that are arriving. There is lesser time with the care provider to explain what interventions are being done. But having said that, none of it justifies this kind of behavior. But it is true that as you go higher up in the ladder of care provision, it becomes more difficult and more abusive to seek care. I will stop there unless there are any specific questions for me. I'm leaving one final paper in the chat. It's about obstetric violence and how complicated this issue is. And it's written by three people, three of my colleagues, and it's written from colleagues who work in different continents and what obstetric violence looks like. I think my parting thought is obstetric violence looks very much like any other gender-based violence is. It's very much like intimate partner violence. It's very much like domestic violence. And the reasons are very similar. What is different is the people who are abusing. And it's more complicated because it's easier to point fingers at a husband or a partner or in-laws or family members when other forms of gender-based violence occurs. But when you look at obstetric violence, it's difficult to call out the perpetrator and it's difficult to address because there is a massive power-based imbalance between the person who has come to seek care, who's usually coming from a very rural, very poor, impoverished background, and the healthcare providers are often the most known, the most powerful people in that area in terms of knowledge, in terms of just the fact that I am able to treat you and make you feel better and make your pain maybe go away. So please do pay attention to gender-based reasons and power-based issues as well when it comes to talking about any form of gender-based violence and any form of other reproductive injustices for that matter. On that note, I would hand it over to the organizers if there are any questions for me. But thank you so much for the discussion.
Thank you so much for being here, ma'am. The discussion is great. We didn't want to stop it, but due to time constraints, again, thank you so much for being here. Divya will take over.
Thank you. Now it is my pleasure to introduce Ms. Nanditta Batra, who is a distinguished legal academician turned practicing lawyer with over a decade of teaching experience at premier Indian law institutes. Now practicing at the Supreme Court of India, her expertise spans public health law, feminist jurisprudence, gender studies, criminal law, and intellectual property rights, making her a leading voice at the intersection of law, equity, and social justice. We are truly honored to have you with us today, ma'am, and we look forward for your insights on this topic, medical negligence in labor and delivery.
Thanks, Divya, for having me. I hope I'm audible and visible to everyone.
Yes, ma'am.
Yes, ma'am.
All right. Let's go ahead then. See, I have been given a very important topic today to deliver, not to say that the others were not important. I was truly flabbergasted and amazed by the way Kaveri was discussing, and I also wanted that to continue because that's one of the issues that, I have also come across both as a female undergoing care of a gynecologist and also what people tell me. So thanks to the organizers for having a wonderful array of speakers and the kind of topics that you've chosen that show the sensitivity of the young learners that you are. All right, coming back to the discussion that I have been interested with, it's medical negligence in delivery and labor. Before I begin, I have a question to the community here. Do you understand what is medical negligence? And do you think, the second question is, if you understand what is medical negligence, do you think that the rules for medical negligence in delivery and labor are different from what they generally apply? That's a common question to everyone because I do not know. I mean, I believe that all of you are students in your postgraduate studies, but I'm really not sure about where you are placed and what is your level of education. But anything on medical negligence that you know, and does it differ by specialty to specialty is a question that I have just to assess the basic knowledge. Anyone? Yes, Ananya, please go ahead.
Good evening, ma'am.
Yeah.
So medical negligence is when a healthcare professional could fail to provide the accepted standard of care, either intentionally or unknowingly, causing injury or harm to the patient.
Okay, intentionally or unknowingly, you've used two words which are quite contradictory to each other. And I'll tell you why they're contradictory to each other and why this basic discussion then becomes important apart from the cases that I want to discuss. You're correct when you say that medical negligence is committed by a healthcare professional when he does not follow or she does not follow a particular standard. But the fact that whether it is intentional or whether it is unknowingly can make a sea of the difference. Why I say that? If it is intentionally done, then it is no longer negligence. Then it's a culpable act. You are premeditating something. Negligence is where you have a duty to care, but because of certain reasons, because of your ignorance, or you don't care attitude, basically you just ignore. But if you intend to produce a result, one that brings in the applicability of criminal law, and that takes the act beyond the sweep of just being a civil act. And then the charges may not just be for criminal negligence. And as Kaveri was pointing out, that though we don't have cases on violence in, recognized violence in India, but then that can translate to whatever harm has been caused within the realm of criminal law. Then the fact that the act was done in a medical setting is not a defense, unless and until you can show that it was done for the good of the person. So therefore, medical negligence, I am just going back to the basics, definitely is violation from the expected protocol, or the fact that you do not have recognized qualifications, you're not qualified to do what you're doing. That would entail the simplest understanding of medical negligence. But please understand, medical negligence, depending upon the shades of it, can qualify definitely as a civil wrong, but also in certain cases as a criminal offense. So when we say that the negligence is gross negligence, it's the criminal law that applies. But when it is intentional, then it can, if it results in the death of the person, then it can be culpable homicide not amounting to murder, or it can be murder also in certain cases. So that intention depends. In fact, one of the defenses that doctors take is that we never intended to court, we were doing it for the good of our patient. But if that good faith goes missing, then the shades differ. So that's the basic. Now please come back to the second question that I had. Do you think medical negligence will differ from specialty to specialty? Like the general discussion that we've just had, do you think that there are standards of care for gynecologists at a higher pedestal than they are for a general physician? Anyone, please raise your hands. No? All right, let me bifurcate it for you. See, since we said that there is a standard protocol that you're expected to follow, at least that is the bare minimum threshold. That's not the maximum that you're supposed to do, but that's the bare minimum guidance. The bare minimum guidance will differ from specialty to specialty. What may be the bare minimum thing required to be done by an ophthalmologist may not be required to be done by gynecologist. I mean, you can't expect him to sterile your eyes and then provide the care. It will also depend upon what problem you're treating, what part of organ or what organ you are dealing with. But the thumb line remains the same, that you have to be duly qualified in doing whatever you're doing. You have to follow, as per your specialty, the standard protocol. The deviation from standard protocol should not be there. The basic protocol. The fact that you're going for something which is extraordinary is not medical negligence if your facts and circumstance justify that, and you have obtained proper consent that, see, this may not be the standard line of treatment. I'm going for a riskier procedure for XYZ reasons. You document that, take the approvals, and then go ahead with it. The risk obviously is involved with each and every specialty, but the thumb rules of what is medical negligence, that remains the same for either gynecological care or for any other specialty for that matter. However, as I said, that because there are certain standard protocols which are there, the duty to care remains the same. The duty to care towards the patient remains the same. However, in gynecological care, you will see that the facts represent a little bit of trickier situation than in the other specialties. The reason being that in gynecology, you're not just dealing, in not all gynecology is related to childbirth, but in certain cases, majority of your cases, you would be dealing with uh, a living person and a person who is yet to be born. or at times at the fulcrum, a living person and a just born person, a child. So you're dealing with two lives which may not be there in other specialities. And now when you have two individuals, the questions that generally arise, with towards whom do you have the duty of care? Is it only vis-a-vis the mother who was your patient, or is it vis-a-vis the person that you have just received in your arms? So these are some of the questions that continue to confront gynecologists. I have been tasked with 3 cases, and all 3 of them are leading cases insofar as medical negligence in labor care is concerned. I'm really not sure if you're going to break out into different sessions and then do the discussion, or should I just share my screen, start with the case and ask questions to the group? I mean, if you can provide me clarity on the format, I think we can go ahead. Yeah.
It was initially scheduled to be breakout rooms, but seeing as we had extended our time, we shall continue with the discussion here itself.
All right. So what I'm going to do is I'm going to share 3 cases with you. I'm going to share my screen and let's try to understand, as you have yourself labeled it, what went wrong or what did not go wrong, because not in all cases. I'll just show my screen anyway. So what went wrong and what did not? The problem with Google Chrome, this Google Meet is that I may not be able to see all of you. So in case there is any problem with my screen, just let me know. Okay, the first case, yeah.
1 second. If you'd like, we can share the screen for, if you're sharing the PDF, our team can do that.
That's okay. I'll do it because I've marked on it.
Okay.
It will waste time in case there is a difficult, in case I send these marked PDFs to you. All right. Yes. The first case that we're going to examine is the case in which decision has come by the Delhi Medical Council, which has been upheld by the National Medical Council. However, before I go to the case law, I just want to understand from you whether you understand the procedure that applies in cases of medical negligence. Like, what are the authorities before whom the complaint can be made? Do you have some clarity on that? Yes, no would help me because I can't see you. I'll just pause for a minute maybe. Yeah. You have clarity, right? That basic concept, where can complaints of medical negligence be made? All right. Just to brush up, I'll tell you. See, a person who complains of medical negligence can approach the state medical council. There can be a complaint to the state medical council. He can also straight away go to the consumer forum and file a complaint. The person, if he thinks is not just a case of negligence, but a case of gross negligence, can also file a criminal complaint or an FIR. All these are overlapping mechanisms. So at times you will see that one incident has resulted in multiple legal proceedings, one before the state medical council, the other before a consumer forum, and the third one for a criminal complaint. Why this multiplicity is because you're essentially seeking a different relief on the same facts. When you go to SMC, you are basically trying to say that this person is not competent to practice and therefore he's a risk to the life of the other patients. He should be warned or his license should be suspended. When you go to the state, when you go to the consumer forum, you're basically asking for compensation. That harm has been caused to me. Now compensate me for whatever I have lost. Please understand that the state medical councils cannot compensate. So therefore, this duplicity is there. The third duplicity, which I said, was an FIR or a complaint case, is if the patient feels that, what has happened with me is not just a civil wrong, it's a criminal wrong. It is an offense that has happened with me. It's gross negligence. And the doctor should not only compensate me, but also should be punished, should be behind the bars. Then the person definitely goes to the court of law or to the police to register an FIR. However, please understand that it is virtually very difficult these days to proceed criminally against doctors because of one of the judgments that we've had, which is Jacob Matthews' case, which means that though an FIR can be registered, but the police will not arrest the person unless and until the state medical council itself or there is a medical board which is constituted is of the prima facie opinion that the case should be made out. Is made out against the doctor. But these are three avenues, which are possible. And why I thought it necessary to do a repetition of what you already know is because in these three cases that we're going to discuss, you will find someone has gone to Delhi Medical Council, the other one has landed before a police, the third one has landed before a consumer forum. So I just thought that, to avoid any confusion regarding the multiplicity of fora in which the cases have been brought, let me do this caveat at the beginning. All right, I'll just start sharing my screen again. Just give me a second. I hope the screen is visible again.
Yes, ma'am.
All right. So in this case, what had happened? This is the case of Saroj Hospital. What had happened? It's not possible for me to run through the entire facts, but I'll just tell you what happened here. What had happened in this case was that there was a lady who was complaining about profuse bleeding. She was on her periods and she was complaining about the bleeding that happened. She consulted a hospital, Saroj Super Speciality Hospital. She went in the morning. The doctor advised certain tests to her. I will take you to the facts. Yeah, you can look at the facts on the screen. I've highlighted it here. She went to the hospital. The doctor asked for an ultrasound to be performed. Ultrasound was performed, and it appeared to be a case of fibroids in her uterus, which were causing the bleeding. And the question then was, what should have been the standard line of treatment? I'll pause here for a minute. Pause sharing the screen for a minute. Please tell me, what is the standard line of treatment if someone comes and complains about excessive bleeding? What do you do? What is the standard medical protocol regarding such cases? Yes, please, anyone? Okay, I'll give you an option. Maybe let's play a KBC here. Option number 1, do you direct a hysterectomy to be performed, removal of uterus to be performed immediately? Option number 1. Option number 2, do you go for certain conservative treatment, give some medicines? 3, do you require, apart from ultrasound, certain other advanced tests to be performed to understand the nature of the bleeding? Option number 4, you do nothing and you just dismiss it as a case requiring no care, saying it's a natural phenomena. So 4 options are there. What do you do? Yes, Dr. Raju, go ahead.
First, what we would do is we'll try and make sure that we'll medically manage it. First, we'll admit the patient actually. We won't let her go. And we'll first admit the patient and then we'll make sure we give medications. But if it's a severe emergency and if it's a very profuse bleeding, it's the call of the surgeon, the call of the physician who's treating. She might even be taken for surgery, but medical treatment is the mainstay first line treatment in any sort of cases.
Okay.
And then we
I have a
proceed to
counter
surgery.
to this. When you say profuse bleeding requiring emergency surgery, what is the threshold for that? Is anything indicated by your practice?
So generally, what I see in my hospital, they say more than we have like a pictorial based assessment charts. Like for example, okay, we have this much fistful of clots. So a fistful of clot is like 300 cc. N number of packs soak is this many cc. So it's actually, as far as I've seen, there is no fixed number. But when it reaches a certain amount, let's say it's like around like 1000 cc or something, people start getting scared and people start acting immediately. But nothing fixed as far as I personally know. I'm just a final year student, so I'm really not sure. As far as I've seen, there's no fixed number threshold where okay things turn around.
I think Dr. Amar J. Sani has joined. He's there for the next session. Hello, Dr. Amar. This is Nanditta here. I'm continuing in the previous session.
Oh, hi.
Hi.
Yeah. Seeing you after a long time.
Yeah, sure, Doctor. Yeah, I'll just finish my session in some time and then
No hurry. Please go ahead.
Okay. Yeah. So what had happened in this case that I was discussing, the doctor had not examined, as Dr. Raju pointed out, the quantum of the blood loss. The doctor had noted that she was bleeding like a tap, and that became a bone of contention between the complainant and the doctor. But I'll tell you what happened subsequently. So once she came, ultrasound was performed. There were other tests which were also performed in this case. For example, her urine tests were performed, her diabetes, her blood sugar was checked, but the results of the other test had not come. And she was admitted in the hospital around the afternoon. And thereafter, a surgery was performed on her in the evening around 4 o'clock for the removal of her uterus. Post-surgery, certain complications developed and she just couldn't recover. Next day, her blood pressure dropped. She had a green vomiting. She was shifted to an ICU. And on the third day, in the night of the second and third day, she died because of certain cardiac conditions that have developed in the meantime. Please understand that this was a case of a super specialty hospital, and the allegations were not qua just the gynecologist, but regarding the team that had managed her. Now, in this case, primarily the allegations though were against the gynecologist, saying that she's the one who treated or misdiagnosed what the event was. The patient's relatives, the husband who had filed the case, made all sorts of allegations that removal of uterus would qualify for this much amount, and he would be getting the reimbursement from the the corporation that he was working in. So they in a jiffy performed the surgery. And the allegation against the doctor was that, a conservative treatment should have been done. And you did not even bother to ask her how her children were born previously. So this lady already had 3 children by the time, she reported of this clinical condition. And there were a lot of corrections which were made in the medical records. So apart from the facts which were there were manipulation of medical records. In fact, the surgery which was done was also recorded, because this lady had to go next day to deliver a lecture, and she wanted to use this case as one of the instances. However, the recording was stopped at various moments, and I understand, I'm not going to that debate, how live streaming of surgeries or how recording of surgeries has exacerbated or affected medical practice, but that's one of the concerns that NMC is dealing with today. Coming back to the facts of the case, so the question in this case was that whether the doctor has been negligent in performing what she did. So in this case, she had complained of being a sugar patient. Her blood sugar was low, her BP was low, and the doctor still went ahead with the surgery. And the question was that it was a laparoscopic surgery. So the question was, what can you do in a laparoscopic surgery, and whether she was even qualified to perform the laparoscopic surgery. There were questions on her degree, because she'd obtained her primary degree from Moscow. So all those questions were there in this. So what happened was that the medical council, after it received the complaint, it issued notice to the doctor, the gynecologist, and the other team of doctors, and all their written statements were on record. However, after examining the record, I'll just share the screen again. After examining the records of the case and the manipulations, the cutting in the medical record was viewed very seriously. The medical commission So the medical council came to an opinion that there was a failure of the doctor in properly maintaining the patient as per the standard protocol. And as some of you pointed out, the standard protocol in this case was to conservatively manage. In this case, the medicine was given to conservatively manage her only around 1 o'clock. And at 2 o'clock, the decision was taken to perform the surgery. So even for conservative treatment, there should have been some time which should have been there. And again, the time in which the doctor was contacted, the communication that they made with the patients and what was there on the written records was very different. And even the person who performed PAC, or pre-anesthesia clearance, even he was indicted, he was given a warning because he did not check up a lot of things like blood sugar, and the fact that the surgery itself was done without getting the reports, all the reports, without examining whether this person has some UTI or not, that led to a lot of errors hinting at the, again, disregard of the doctors towards the welfare of the patient. So therefore, it was a case of established negligence. So one of the learnings that we have from the case is, even if it is an emergency care, please take care to wait at least for the medical reports of the doctor. If you've ordered certain investigations or whatever investigations you need to have a comprehensive view, at least wait for them unless and until it's a life and death situation, which was certainly not the case. It was made a life and death situation post the surgical operation which was done. She'd been complaining for 2 days about it. And don't manipulate the medical records. Manipulation of medical records because they're in your custody goes against the doctor. So the overwriting which was done in this case was viewed very seriously. And that's what it led to the finding. I'll just share the screen with you, not referring to the entire case. This is the written statement. I'll straight away take you to the findings of the case. Just a second. Yeah. So here are the observations. So whatever I've discussed, the observations are at page number 61. I'll just read it from here. Sorry. In view of the above, the questions were these. So they are the observations, they are the facts. Let's look at here. After reviewing the records of history, examination, investigation, surgery, it seems that the urgency of going for emergency hysterectomy, especially in view of multiple comorbidities and the fact that patient was in menstrual period, is unjustified. Please understand that the surgery was done when she was still on her periods. We are of the opinion that the initial medical management should have been to bring up the hemoglobin level, control heavy menstrual bleeding, correct, optimize the comorbidities, rather than resorting to emergency hysterectomy, especially in a patient who had previous 3 pelvic surgeries, which made her a high risk from a surgical point of view. And again, what was to be done? There were certain additional procedures which were also undertaken in this case. So the question, what was the need? They were not warranted. So that was also one of the findings here. And the PAC sheet does not mention hypothyroidism and diabetes. So they indicted the person who had performed the PAC also. In this case, one of the additional facts, if you've read the case, is also about her hemoglobin levels. So her hemoglobin at the beginning was 7.2, but every day when it was examined, on one day it is 10, on another day it is 13. The question is how it can change. So there were questions that whether she was given a blood transfusion or not, which could not be explained by the doctors. The doctors said that we gave blood transfusion, but the records were not properly maintained vis-a-vis the same. So that was one instance where clearly there is a manipulation and the surgery has been performed in a hurry, without documenting, without medical, I mean, even if there was medical necessity, the documents did not show the medical necessity, and it was done without sufficient protocols. The other case that I wanted to discuss with you was a case where the doctor has not been held liable. It's a recent case by the Supreme Court. The judgment has come by Supreme Court. It's called the Deep Nursing Home versus Manmeet Singh Mattewal. So in that case, what had happened was that there was this lady who, when she was 32 weeks pregnant, I'll just share my screen again. Yeah.
Ma'am, can we continue this session after during the documentation and confidentiality, ma'am?
Yeah, sure. I'll stop here then. We'll continue with the two cases at 8 o'clock.
Yes, ma'am. Sorry for the interruption and thank you.
That's okay. That's okay.
And now it is my privilege to introduce Dr. Amar Jaisani, a distinguished independent researcher and teacher in bioethics and public health. He is one of the founders of the Forum of Medical Ethics Society and served as the editor of Indian Journal of Medical Ethics. And he has also served on numerous national and international research ethics boards and a visiting faculty at leading bioethics centers in India, Pakistan, and Kenya. In 2020-22, he was honored with the award of Bioethics Service in the face of challenges by the International Association of Bioethics, recognizing his remarkable contributions to the field. We are truly honored to have you with us today, sir, for the topic, legal aspects of abortion.
Oh, hi. Good evening to everybody. I was told that we are going to discuss some cases here. Was there any discussion among the participants on the cases? And
no, sir, but participants would be presenting the cases now, sir. Like we have given the cases. Now
have they discussed among themselves and they have
now we will have the discussion, sir.
So because we went a little overboard with time, so now what we're planning to do is present the case in session and then have participants deliberate on it.
So which case do you want to discuss? The first one where...
Sure, sir. We shall discuss the first. Yes, sir. We'll have our teammate share their screen and then we could begin with the first case.
Can somebody present this case and then we can discuss it? That's not a problem for me.
Yes, sir. So here we have the case of late-term termination clinical negligence, the death of Dr. Rupa Datta in New Delhi in 2023. So at 26 weeks of gestation, she was admitted to Sri Mulchand Ram Hospital for an MTP because of suspected fetal anomalies. During the procedure, she spontaneously aborted but retained the placenta. As preparations began for manual removal of the placenta, she developed severe bronchospasm and aspiration pneumonitis, leading to her death. The NCDRC found the hospital and the treating gynecologist guilty of gross medical negligence and cited multiple lapses, performing an MTP beyond 24 weeks legal limit without statutory approval, failing to adequately manage known asthmatic risk and poor emergency preparedness. The commission then awarded 1 crore as a compensation to her family, and the effective reproductive care requires a balance of clinical urgency, legal compliance, and ethical responsibility. And this case was seen as a deviation from all of these.
Okay. So what do you think? Anybody having any opinion here on the case? I mean, few things I can see glaringly. One is that it was more beyond the 24 week of gestation as allowed by the law, and beyond that, you require more elaborate consultation in order to carry out the abortion. That is one. It is claimed here that there was a spontaneous abortion, while the judgment says that there was an MTP carried out. Now, there seems to be, real difference in the way court has looked at and the way the doctors have claimed here. And the patient is a doctor, right? Patient who died was a doctor. So, from your own experience of what is happening in the hospital, I don't know. I no longer work in the hospital. I'm a researcher, and particularly public health researcher. I'm also not a lawyer, by the way. So I don't know as much law as Nanditta would knows about it. So, what do you think must have happened in this case? What is your guesswork? Anybody has any opinion on this? What is the abortion procedure that you carry out when the stage of gestation is beyond 24th week? Yeah, please go ahead, Tanya.
So from my knowledge, I have heard that so if it's before 20 weeks of gestation, using one medical professional can approve it. But when it goes past, I believe, 24 weeks, it requires at least two medical professionals
right.
to approve the abortion. After that, there are like certain applications in case if it's a minor or if it was cases of assault or in cases of fetal anomalies, like in this case, then exceptions can be made. But primarily, the basic is that if it's past 24 weeks, at least two or more medical professionals are supposed to approve the procedure.
Yeah. So, what procedure you carry out if the gestation period is beyond 24 weeks? Do you do simple DNC or you do something else? What exactly is that? How the procedure is carried out in the late gestation pregnancies? It is an induced labor, isn't it? How you do it?
Labor is induced, and
Right.
yes, sir.
I'm not a gynecologist. That's why I would like to ascertain now that normally it is you inject the saline and you induce the labor, and what we call the premature delivery is to be carried out when the fetus is because you have injected saline, the fetus has died, and you take it out, isn't it? So it is more like a miniature labor, and after the labor, the placenta did not come out, and so this whole problem occurred here, isn't it? So the whole claim that there was a spontaneous abortion becomes suspect. That is what the court also looked at it and said that they had carried out the MTP and not the spontaneous abortion had not taken place. So there are two different aspects, because the first part of the judgment is that they violated the MTP Act. And if it was a spontaneous abortion and then placenta did not come out and then you intervene, and if there was a death, then it would have been a simple case of medical negligence. Here it is connected to the MTP simply because there was a MTP carried out, you see. And the procedure for carrying out MTP, the legal procedure, was not duly followed because it was after 24 weeks of gestation. In certain cases, you have a medical board's permission required. So those kind of things are not carried out here. So this is a case where you find that what we oftentimes do, is to induce the labor prematurely by injecting, fluid and bring out the dead fetus. This is done quite often, even without requirement of the MTP Act being met. And I've seen it happening in quite a few hospitals, which informally is done. Or you think that is not being done? I don't know. My experience is that I have seen a lot of people doing it. Anybody? Anybody would like to have any opinion on this?
So this was one discussion that we had yesterday as well about if it is beyond 24 weeks, um, people might end up opting for a rather unsafe and an illegal means of abortion if they want to get it done anyway. So one question that an audience member had asked yesterday is if there's any chance in the future that we would increase the limit for MTP from 24 weeks.
Well, this is a hypothetical question at the moment. If
So do we see it
government,
going anywhere?
because if you read, I think well-known judgment of Chief, Chief Justice Chandrachud in 2022, which was against the Principal Secretary of Government of Delhi, where the whole issue was discussed quite in detail. It is a long judgment. I think it is about how many? 75 pages long judgment, where an unmarried woman was denied abortion, and then Supreme Court ordered that it should be carried out. There, he goes into details of this issue, saying that the Abortion Act is actually not essentially a right to abortion for the women. Abortion Act only does one thing, that under the Indian Penal Code, where the abortion remains, a criminal activity, it provides an exception to those abortions which are carried out under the medical supervision as per the Medical Termination of the Pregnancy Act as being not a criminal abortion. The rest are all criminal abortion according to the law as it stands. So actually, the Abortion Act, as we talk about, is provides some kind of liberty to the doctors to make a judgment based on the what woman is requesting, and carry out the medical termination as per the requirement of the law and the rules under the law. So there are people, particularly those who are for the reproductive rights and feminist groups and all, they have made a strong plea saying that it should be made the unconditional right of the women to have abortion. And if that happens, then the limit will be infinite, till the end that women can look for abortion. But till then, this is a midway which is connected to what is called viability of the fetus. And so far, they have put limit to the 24. Earlier it was 20, it has made 24, and then for certain exceptional cases like fetal deformities and other issues, up to 28. So this is how the whole legal framework of the abortion is there. So keep that in mind. It will be good if it is extended, and one should agitate for it. But at the same time, the international political movement, as well as even in India, there are a lot of people who are not so much in favor of supporting the right to abortion. I don't know to what extent the doctors are unconditionally supporting the right to abortion for the women. I met a lot of doctors in recent times who are not so happy about it. I can give you one example. I think in one of the Supreme Court cases, the All India Institute of Medical Sciences Medical Board was asked to tell the court about whether it would be safe to carry out an abortion, where the board, goes and says that, yeah, we can carry out the abortion, it will be safe, but we'll be killing the fetus, because fetus is more than 24 weeks gestation. And at that time, one of the judge said that, no, we don't want you to kill the fetus. Now, this is quite a unusual thing that happened, simply because abortion at any stage, even the earliest stage, is definitely killing of the fetus, whether you like it or not. The fetus is dead, and once you do abortion. So that is whether it is a do it in early stage or you do it in the late stage, both of these things is the same. The only thing that cuts off for the moderate position is that what is the fetal viability? And the fetal viability is at up to certain extent. Then beyond that, there should be certain consideration for deciding. So this is the limit that has been placed. And where much depends upon what kind of movement ultimately forces the government to liberalize or to restrict will determine up to what stage the abortion will be made available. Like say in USA, I don't know how many of you have read the judgment of the US Supreme Court, which had shifted from early 70s judgment of providing liberalized abortion to almost effectively prohibit the abortion. We ran two major editorials on this subject in Indian Journal of Medical Ethics. If anyone who is interested, you can have a look at it. It is written by a well-known feminist bioethicist, Ruth Macklin. And it really dissects the whole stuff, saying that it is the pressure, political pressure of the conservatives who have actually made it happen. And that can happen in India also if the political conservatism increases. There you can say that religion played role. But as far as religions are concerned, there is no religion that I know of condones abortion, Hinduism included. We believe in Jivatma. That means even from the very point of conception, it is believed that the fetus is a person. So that's the whole gamut of the things which is acting against it. So to protect the right of women to have abortion is a medical and public health necessity. But at the same time, there are forces in the society which are trying to restrict it. And if doctors become part of those forces, as well as the judiciary and the lawyers become part of those conservative forces, then there is a possibility that there will be more restrictions in coming time rather than independence or liberalization of the abortion. So I agree with you that the limit should be increased, but it is not going to be an easy path to travel. I'm basically a bioethicist. I won't talk like a lawyer. I will talk like more of a philosophical analysis of the whole situation or political analysis of the whole situation. So that is what is the situation there. I think on this case, there are few questions that are raised. Three questions I could see. How should clinicians navigate compassionate late-term MTP requests within the legal limits? Second is, what safeguards can hospitals implement to prevent similar procedural and ethical failure? Should special review boards be mandatory for post-24 fetal anomaly termination? So these are the three major questions which are raised here. I don't know the last question if you take first, because you all are from medicine. So far what has been happening is that in the specific cases going to the court, such boards have been formed. But if there are permanent boards formed, then you may have to have such boards all over the country. Every district or every primary health center or the community health center needs to have. Because how many women who require late-term abortion can go to the capital city of the state and go to the tertiary hospital there where the board is located and try to get their permission. By the time they do it, it will be so late term that board will not allow it to happen, because there is a lot of time loss in that. Few cases which have gone to High Court and Supreme Court has used the boards and things have worked. But I don't know how to practically to ensure that every woman gets the access to the advice of the board on the subject, and so that the doctors who intend to carry out the procedure, they are safeguarded with the board's opinion. But that doesn't seem to be a system in place at the moment. But else, I think medical profession, the obstetric and gynecology should be demanding that, or saying that uh, the institution where it is to be carried out, that those institutions should be empowered to have their own board, there in order to take decisions. So, but those boards to be created, I know that for ethics review of research, the institutional review board in their formation and making them uh, permanent in every institution, and then to get them registered with the government agency like the Department of Health Research took us 20 years. We started in 25 years actually. When the 2000 guidelines of the ICMR came out, that was the recommendation, and it ultimately got implemented only in after 2013 and 19. 2019 was the watershed when the new drugs and clinical trials rules were brought in. But till then, it was not mandatory, and it did not work, properly. So this is a challenge for us to create a system which is efficient enough to give a medical opinion on time, so that gynecologists who wants to carry out this procedure at the request and consent of the woman can undertake it, in the late gestation pregnancy. So I think that also provides you answer to the first question also, that how should clinician navigate? I think the clinician and we as a profession, larger profession, medical association, FOXI, as well as the medical council have responsibility to assist the government to ensure that this kind of boards are available to in an efficient manner. And if not, then they should simplify the law and the procedure, that even after 24 weeks, if not two, more than three medical professionals giving opinion made sufficient for undertaking this procedure in certain condition as provided under the law. So this is what is feasible to do. The death in this case is I don't know. I have not seen the details of the judgment or medical record to make a comment whether the death took place because of the negligence. Negligence issue is about what kind of medical standards were used in this case while undertaking this procedure. What were the critical conditions or untoward incidents that they should have anticipated from the very beginning, and response to those situations kept prepared in the hospital when they were doing it. This is what ultimately decides whether there was a negligence or not. Here it seems the court has come to the conclusion that there was a negligence involved, because violation of medical termination of pregnancy act does not give you compensation. It actually leads to criminal issue. While the negligence, which is a civil issue here, the civil negligence, that provides you monetary compensation, and they're given 1 crore rupees. So it seems that the court was satisfied that there was a medical negligence involved in this case. So this is what my interpretation there. Any other case that you would like to discuss, or if you have any other point on, anybody has any other point on this case, we can discuss that also. I think the third case is similar to this. Unmarried woman's case, This is a very interesting issue about the unmarried woman. Why should a marriage be a criteria for providing abortion to the woman who is adult? I just don't understand. I also know that when earlier research we had carried out, we found that during the MTP, there was a demand for having consent from the husband of the woman. None of those things are required, as far as I understand. And the issue of marriage, which has crept in the new, rules which are made, is by that I think 2022 judgment, where the Chandrachud has made it very, very clear that your understanding of women's relationship now should be very, very different from what it was, when the MTP Act was formulated earlier. So, where it makes it very clear that unmarried women who are having live in relationship, all those things, live in relationship and all those things are covered there. And I don't think law demands that there should be a consent of the husband or the partner for undertaking abortion. But many doctors demand it, fearing that there will be repercussions and there will be some kind of a cases against them in case husband has not agreed. But legally requirement, as far as I understand, is not there. Would you like to go into the details of the case if you want to have?
So could we discuss case 2? Because there is NTP as well as POXO in it. So that's something that I'd like to
Yeah, please go
hear
ahead.
about.
That is
Yes.
about the unmarried minor woman, right?
Yes,
And
sir.
yeah, that is very important. Yes. Can you just go through the case so that everybody knows it?
Yes, sir. It is a case of Dr. Janmaga Lakshmi versus State of Tamil Nadu in the Madras High Court last year, 2024, where a senior gynecologist was accused of performing an illegal operation on a minor and not reporting it under POXO. The patient had presented as 18 years old. Her documentation supported the claim. So the doctor argued that she had no actual knowledge of the girl's minority and had performed the termination lawfully within MTP Act provisions. And the Madras High Court quashed the FIR, holding that liability under POXO arises only when the doctor has direct awareness or evidence of minority. The case underscores the ethical line between mandatory reporting and patient confidentiality in reproductive healthcare. It reveals how misplaced and premature criminalization can erode trust and deter doctors from providing timely care. So we have both POXO as well as MTP, but mostly also the limits of actual knowledge. So I'd like to hear your thoughts on this.
Yeah, even before POXO came, this issue was always there. Earlier the age at consent for sexual intercourse was 16, and the 18th was consent as a majority. When a person becomes majority, but for sexual intercourse, the consent age was kept 16. When the POXO came, it changed and everything became 18. But I remember one case 10 years back, which we have published a case study in Indian Journal of Medical Ethics. And it happened in Tamil Nadu, where there were researchers who were studying abortion. And when they went to a hospital ward, a public hospital ward, they found that a girl was provided abortion, who was less than 18 years of age, and less than 16 years of age. So 16 years was the consent, the age of consent at that time. And they also inserted without any consent a property. There was a government's policy that there should be intrauterine contraceptive device. Now this was a research project. They did the observation when they were doing the interviews in the ward, and they took this issue because they felt very uneasy about it. So they took this issue to the Institutional Review Board, what IRB or AIC, that is the Research Ethics Committee. And a lawyer who sitting in the research ethics committee, she felt that providing abortion to this girl who is less than 16 years old without reporting it as a statutory rape was not legally correct. Um, the consent on behalf of the girl was given by the grandmother of the girl, because she was less than 16, so she had no right to give consent. So this is your guardian has to come forward to give consent. So this became very big issue, and there were inquiries of the government. Ultimately, I don't know where the case went, but I think it fizzled out at the end. Nothing was done to the doctor or the hospital. But this issue keeps coming up, and I think now the Supreme Court has taken in some judgments a position that there needs to be more flexibility, and the doctor should not be made to report. And I think the High Court has also uh, uh, taken this kind of position and said that it cannot be made mandatory reporting by the doctors. The mandatory reporting issue is always problematic. The mandatory reporting of the diseases, mandatory reporting of, say, the domestic violence, uh, and those kind of stuff. That is where things come up. So, I mean, historically, if you see in different countries, like in US in 90s when I was studying domestic violence, they had passed a law saying that doctors should be mandatory reporting domestic violence if during the history taking they find that injury sustained where because of the domestic violence or irrespective of the injury found, the woman has complained of the domestic violence, and the law was that the doctor should be mandatorily reporting. And the medical association there, uh, American Medical Association, had a long campaign saying that this kind of mandatory reporting is not correct. So they gave instruction to the doctors that when any woman comes to you and you are taking history, you tell the woman that if you report domestic violence to me, then I have an obligation to report it to the government or authorities. And so that way, they try to find a way out, but that was not a good way out. Ultimately, the whole mandatory reporting of the domestic violence requirement was taken out, although it still remains a part of provision of the services. If there is a domestic violence, the doctor is supposed to provide, the services to the woman as per the requirement of the law. We have a domestic violence act here, where there are provisions for providing services to them. And I think in last 10, 15 years, the Dilasa model, which was developed in Mumbai about one-stop crisis center in the public hospital, has been replicated in large number of hospitals with the government support in public hospital. So those are the centers which now provide support where the references are given by the doctors for them. Now, in case of this kind of stuff, where a minor woman, a girl, is pregnant and comes to the doctor, the doctor either tells the patient from the beginning that, well, if you tell me that you are minor, I will not be able to carry out. And most of the time, what happens that the parents and the minor girl know that the doctor will not be carrying it out. So they lie to the doctor, and doctor has no way to find out unless he insists that show the birth certificate. And in India, everybody doesn't have the birth certificate available. So making even a demand of that is problematic. Or, ask for other documentation and all, ask for Aadhaar card and this and that. And that means doctors have to become detectives, to find this out, right? Otherwise, if you try to medically establish what is the age of the girl, that would be very tedious process and very expensive process. So those are the keeping those things in mind, I think the court has taken a very good way out and said that this should not be treated in this manner, and there should be more sensitivity, and the doctor should not be made to do the mandatory reporting. So this is what seems to be the gist of the judgment, and to me, it is a very important that everybody knows about it, so that the minor girls who come for the requirement of abortion because of their life's condition with their parents, I mean, guardian has to give parent or the legal guardian has to give consent for the undertaking MTP in such cases if they declare that she is a minor, where I think there is a flexibility provided, and I hope that works very well, so that such at a such tender age, the girl doesn't have to go for the illegal abortion, which may be done in a substandard condition and suffer from it. So I find it's a good judgment, and all of you should be aware of it.
So in this case, there are two things. Um, one is that mandatory reporting, which you said has been done away with. The other part is the age of consent and the limit being 18. Do we, and also because this has happened a couple of times, do we see it going back to, say, 16 at all?
It's a good question. I would suggest that it should be like that, because the way our society is evolving is that every individual, youngsters particularly, because of the exposure to the education, I mean, there is more education now as compared to, say, 30, 40 years back, and exposure to mass media as well as internet and other things. They become more aware of about themselves, about their sexuality, and they do get involved in having relationships. So this is not a specific phenomenon of India, but has happened all over as the education increased and more confident youngsters started coming up in the society. So this is where they are asserting their right about, and sometimes they do it as a rebellion against family authority or the societal authority or the moral police and all kind of stuff. So this is happening more and more, and given that situation, I think we require more understanding among the lawmakers on this subject, and they should find that different scales for the sexual activity needs to be implemented. You may go back to 16 or you go back to 14. That will very much depend upon how at the end a compromise at the societal level or political level emerges. But yes, there is a need for having that dialogue, and perhaps medical profession can put its weight behind it if they are finding that there are many such cases are coming to them. And if a woman was coerced in sexual activity or she was raped, then it is up to the woman to go and complain about it and file a case and then take action, or the family members can do it along with her. But to make a doctor to do it is where you say that below a certain age, if there is any sexual activity you find. Now forget about abortion. Here she is pregnant and she has come to you. But you find a 16 years or 15 years old woman asking you for advice for contraception. Okay, and you ask the question that why do you want advice for contraception? And she said that, well, I'm sexually active and I would like to protect myself, both from a pregnancy as well as from the sexually transmitted disease. So I want to learn from you. Can you tell me? And they said, oh, Now I have, I know, uh, uh, um, here information that she is sexually active, and that under this law is wrong. How can any man have sex with a woman, a girl who is less than 18 years old? Are you supposed to report that also to the police? This is a problem. So that's how what I say is that there is a more debate and discussion required, and if we come out with more data on the subject, I think there should be more research carried out by the public health people on the reproductive health part of it, and see that uh, uh, those data are published in good scientific journal and then used for the advocacy with the politicians and the government to reconsider the law in relation to this aspect. That is what I would suggest. Unfortunately, we don't do good, and regular medical research. But you being postgraduate students, and you may be able to take up projects where you are able to document a large number of cases in your hospital where girls come with different kind of requests to you. MTP is only one. There are others where you, in the course of time, you encounter that the girl is sexually active and she's under 18 and she's having a consensual sex with a boy who is maybe 18 or maybe 20 years old or maybe same age, whatever it is. So you can, if you collect those data and provide scientific evidence that there is a social reality that the medical profession continuously encounter, and to make them, make mandatorily report it to the police authority or any other authority, is not going to solve the social problem that we have here. It has to be done in a more sensitive manner, and the law should be responding to that requirement. So yes, there should be provided sex education. There should be provided education for the safety in the sex, which is most important part. And I find that parents as well as the school teachers are not the right people because they are not able to talk about sex as easily. Well, these youngsters nowadays find out about sex from the internet and other sources, or from the peer, of theirs, and sometimes they find out what they find out is not scientifically good. So there should be more efforts in actually educating them so that even if they become sexually active, they are able to protect themselves properly, and they don't end up with a request for the MTP. That will, at least in many cases, it will get reduced if they are given access to that kind of safety in the sex.
So I have one follow-up sort of final question. When you said there should be more research conducted on whether there are such cases, at what level do you propose we do this? What level do you propose we find the source material? Because even if we encounter them in our hospitals, um, are we sure that the people are willing to sort of at that point provide us with whatever we require for said research? Like the other point source would be cases that are reported, but again, those could be very much an iceberg phenomena. So
No, I can tell you my early experience of in 1980s. As that was the time when I was learning to become researcher, full-time researcher, and I remember clearly that the medical journals of USA and UK, which I was reading them very regularly. There will be at least one article every fortnight about the teenage pregnancies and the teenage sexual activities. I mean, research articles. There was a massive debate and discussion on that because there was a lot of scientific literature was produced. it's not completely impossible to capture the data on this at the hospital level when the young girls come there. You can first do a good survey, or you can do qualitative research where in-depth interviews are carried out. You may have to provide a very strong confidentiality and win their support and ensure that you do not reveal their names even when you come under pressure from the authorities. But it is doable. Those kind of research are doable. Here is a one case of minor case is there. Are there more cases in the hospital coming where the case did not become controversial, you see, and nobody filed a case, but it is done silently by the doctor without creating any ruckus or anybody coming to know about it. And it's done in tertiary hospitals so often. I know about it. The doctors are compassionate people. They would like to help out when somebody is in trouble and provide the services if they are able to do it. And so capturing those data, which is not impossible, although they are difficult. And but if you are living in the hospital, you are working in the hospital, tertiary care center, and the public hospital, you may be able to capture this data. Other, if you don't do that, then without scientific evidence of telling on this, how are you going to, do the advocacy on it as an obstetric and gynecological society? You will have to then depend upon sociological data. That I am primarily a social researcher, do the social science research. I don't do clinical research. You people do clinical research. And there are a lot of studies which are coming out, which are from the community, where the women's researchers are going and trying to find out about what the young girls are doing or young boys are doing. And there is whole adolescent sexuality and adolescent reproductive health issues. There is a massive funding and there is a lot of research carried out, but they are not done in the hospital setting. They are normally done in the community setting. So if they are able to capture this information, then either you use that information for your advocacy. Somebody can do a systematic review of that information available. Or you can also do clinical research in your own hospital and interview young girls who are coming there about their need for contraceptions and their sexual activity. Asking questions, doing those surveys, doing in-depth qualitative research is possible, provided, as a part of your postgraduate project and that kind of stuff. Then in addition to those social scientists, evidence, you will be able to generate evidence from the medical establishment, and putting them together, you may be able to do good advocacy about liberalizing law in a manner as it is required. So yes, it is a little challenging, but not impossible, as far as I understand.
Thank you, sir.
Okay, I think Nanditta should come back now and take up legal cases.
Thank you, sir, for your valuable insights and guiding us through this important discussion on legal aspects of abortion, for spending your time on this case discussion. So thank you so much.
If anybody has any question later on, I can give them my email ID and they can write to me. I'll be very happy to respond to them. Okay, thanks a lot for this invitation and this interaction. Thanks. Bye-bye.
Thank you, sir. Okay, so we'll have Dr. Nanditta join us back for documentation and confidentiality. So in the meanwhile, I think we do have time to sort of go back to our breakout rooms for discussing two cases. So we just have like one case, so you'll have more people in each room. So would that be okay? Just by show of hands, if that works for everybody. So this is our last topic for the day, and we will have two cases, as I previously mentioned, and we'll give you 10 minutes. This time, we'll properly schedule it for about 10 minutes, and then we can go ahead. Okay.
Yes, ma'am. So you may please continue with the like now we invite the breakout rooms to present their cases on documentation and confidentiality.
So there are breakout sessions right now. What is the format? Can you please go ahead with the format?
Yes, ma'am. So for this topic, documentation and confidentiality, we had the breakout room discussion now for the two cases which has been shared. So like yeah, we set of participants where they're in breakout room 1 discussing about a case and breakout room 2 discussing a separate case. So now they'll be presenting their findings here and then we'll be having a collective discussion.
Correct. So I think people from breakout room number 1 can take the lead.
Participants who were there in breakout room 1, I guess Brenda and Harish were there. Can you present your findings about the case now?
Okay, so there was a soldier who went to donate his blood and he was found HIV positive. And the hospital informed it to his family and his fiance without his consent. So I feel that it's very wrong on the part of the hospital. The only way that his family and fiance should have known it should have been through him and not from the hospital. And it is a breach of the confidentiality. And what I feel is that if we don't let our patients trust us, then how will they come to us? So that's it.
Anyone else who would like to comment on this case?
The thing is, it also, because the fiance is involved, there's another person involved. Based on what ma'am you had previously shared about when there's another person involved, how does the doctor really go about it? Because in this case, the doctors did disclose it to the person's fiance, which I think was fair.
Okay.
At least that's my stance.
Okay, so this case happened in 1996. Please understand that at that time, the law, forget about law, think about the scientific developments and the treatment protocol for AIDS in 1996 and what is there in 2025 and 2026. Please understand that there was a lot of stigma attached to AIDS at that time because the treatment protocol was not proper. Medicines were expensive. It is only post 2000 that we've had access to medicines with Cipla and other Indian generics making the combination pill. Before that, AIDS virtually meant a death knell for the person who was infected and also the other persons to whom he was infecting. And this decision by the Supreme Court came in 1998 when the same stigma had lingered on. But a lot of water has flown, though the principles remain the same. Now, while I say that the principles remain the same, please understand that the principles are always applied in a particular socio-economic time. I mean, so those influences you cannot rule out. There is always what I'm saying is with a hindsight bias, but and I'm not trying to justify what the court said at that time, but I'm just trying to make you aware why the court said what it said at that particular point of time and why laws keep on changing. So in this case, Supreme Court did not find any infirmity with what the doctor had done by disclosing to the fiance. However, I just want to make you understand that this case generated a lot of discussion on, as you said, on the confidentiality of the patient. And two important changes happened after this case had happened. One was your IMC Professional Ethic Regulation of 2002. At that time, when this case had happened, it was the 1986 ethics regulation, but 2002 regulations expressly talked about patient confidentiality, though it did not clarify the HIV, the position on HIV, but it did speak about patient confidentiality, as you are trying to say. And ultimately, so there were cases post this that then talked about privacy as being a fundamental right. And ultimately, in 2017, we have the HIV/AIDS Act, which addresses this question that whether it is the duty of the doctor to disclose first. If he discloses, even though there is no duty, whether he has violated any law of the land. So these are the questions, and under what circumstances should he not even volunteer to disclose? So those things have been answered now by the HIV/AIDS Act. So this decision has to be read along with the provisions of the HIV/AIDS Act of 2017. What are the provisions of the HIV/AIDS Act of 2017? Anyone who can tell me that? I'm not going to answer that straight away. What is the current position of law? Anyone would want to take a wild guess? Or if you can open the HIV/AIDS Act, I can guide you to the relevant section. Not interested. I think it's been a long day for all of you. All right. I am just asking you, if it's been a long day, to please refer to Section 9 of the HIV/AIDS Act. That will provide you with the position of the law as it is in 2025. So please read this case with a little skepticism towards the findings. All right. Can we move on to the next one then? Yes, breakout session 2, room 2. Anyone would want to volunteer? What happened here?
Yes, so I'd like to volunteer. So here, basically, it's there's a question about whether to protect this adolescent confidentiality. This adolescent, this 15-year-old girl, has basically approached the center to have an abortion. So the question here is whether to protect her confidentiality or to report it because she's a minor. So the doctor stands for the fact that the girl, though she's a minor, her confidentiality matters just as much as an adult, so it has to be protected, and hence he wouldn't disclose her identity to the police. But the police find it essential because this is considered as a case of statutory rape, because even though it is consensual sexual relationship, it's a result, the pregnancy is a result of a consensual sexual relationship, she's still 15, so she is not really in a position to consent for this. Yeah.
See, this case is basically pointing out towards the conflict or the problem that the law has created. In the sense, on the one hand, you have Section 19 of the POCSO Act, which says any person who has knowledge about an offense vis-a-vis committed vis-a-vis a child must report it to the police. And as you very rightly pointed out, Gitanjali, that because a child getting pregnant below the age of 15 years is possible only because of a sexual activity which is forbidden, the police had the doctor had the duty to report. But the question is, what should be reported? See, what happens a lot of times is, and this is not the first case on this particular aspect, what has happened vis-a-vis minors is that the doctors left, right, and center have refused to terminate the pregnancy of minors, irrespective of the gestational age. Please understand, the MTP Act does not forbid the termination of pregnancy of a minor in any of the ways. It only says when the cases of a minor, the consent of the guardian has to be obtained, because minor is incompetent to give consent. So there is a substituted consent, but it does not say that no minor's pregnancy be terminated, or it does not say that for terminating the pregnancy of the minor, you need a court order. It does not. But what the doctors have found themselves is a kind of legal soup, for the reason that on the one hand, MTP Act does not prohibit them from carrying out the procedures. They fear that they will be prosecuted under other laws. And one of the fears that they have is because of this 2012 Act, that is the Protection of Children from Sexual Offences Act, which makes it mandatory for them to report. As a matter of practice, I don't know on whose advice, what the doctors have started doing is they ask, irrespective of the gestational age, that you go to the court. The minor, they refuse the termination of pregnancy, and they say, if you want termination of pregnancy, get a court order. We will do a termination only if there is a court order. And in many of the cases, you will see a lot of judgments by various high courts saying that the doctor be permitted to carry on the pregnancy, the report be there in a sealed envelope, and then we will see, so on and so forth. So that has been by large. So which means that the doctor has now made legal access a precondition for medical access. So you first go to the court, obtain the degree and the decree, and then come to it. Now, this was a problem which was recognized by the Supreme Court in 2022, and in a judgment which is referred to in this case, the Supreme Court said that we understand that, there is a fear of prosecution, which is a barrier to accessing reproductive health services. Therefore, in cases of consent, I'm sorry, in case of consensual sexual relationships, if there is a request by the minor or her guardian not to report, then the doctor will not divulge her details. See, this judgment itself, I've written a paper on it, it's published by IGME, criticizing the judgment because it does not give very clear guidelines to the doctor as to what to do in those circumstances. It says you have a duty to report. It is not saying, the judgment is nowhere saying that you don't have a duty to report. But what is to be reported has been changed. So it says you tell that there was a minor who came for termination of pregnancy, but you provide no details of the minor. The question essentially is, then what is the police going to do? It's just a mere compliance for the doctor in that case, because no purpose will be solved. And that's exactly the problem that the facts of this case bring about, that the police is now insisting for records. You at least tell us the name, we'll investigate, but the doctor does not provide them. So there is, on one hand, police trying to do its duty, on the other hand, a doctor trying to do its duty. So doctor against this harassment has approached the Bombay High Court in a writ petition. And the question before the Bombay High Court was, what should be the doctor doing in such cases? And the answer is that you cannot compel a doctor to give the details. He has a duty to report. It's a blank report, which is given that there is a minor who had come. And if there is some kind of guidance provided by the minors that, it was a consensual thing, it was the guardian is saying that, then he can be obliged not to share the details. But in any case, they have asked that preservation of the fetus be there because it's forensic evidence. So the position of law is again clarified to a certain extent, but not fully clear. In fact, there is another case pending before the Bombay High Court, which is now examining how the privacy of the adolescents can be protected in such matters. So we will have to look out for that decision. But there is some kind of, legal incongruity, if I would say that, because one act is saying something else, the other indirectly is hinting at something else, and what the guidance which has been given by the courts, that also is not very clear. So as of now, perhaps get an undertaking from the patient or from her guardian that we do not want the disclosures of details to be made to the police. So I think that will help you in due diligence. So this is on documentation and confidentiality. Please understand that these are not the only two cases on documentation and confidentiality. When it comes to reproductive health, you will also have to comply with certain other laws. So for instance, documentation, one of the laws that insists heavily on documentation is your PCPNDT Act. So please ensure that you comply with the provisions of the PCPNDT Act. Ensure that you comply. If it's a reproductive health, today we have assisted reproductive technologies. We have an act on the same, ART Act. We have an act on surrogacy. So there also you will have to document, notwithstanding the confidentiality requirements, proper records have to be maintained. So please ensure that you comply with other applicable laws also. I think I'll stop here, and if there are any questions or concerns, we can go ahead. Or if you want to have a discussion, you have comments, questions, please go ahead. Over to you guys.
Ma'am, one thing was before Dr. Jisani joined, we were discussing that one case. If we could sort of, before we had to abruptly stop that discussion. So if you could sort of just go back to that as well.
Yeah. See, in my previous session, I was tasked to help you navigate the concept of medical negligence. And I basically was tasked to walk you through 3 case laws on medical negligence, especially in the context of delivery and labor. And one of the cases that we discussed was the decision by the Delhi Medical Council in the case of Gargi versus, in the unfortunate death of Miss Gargi Meena by Saroj Super Speciality Hospital. The second case that I wanted to discuss was Manmeet Singh Mattewal's case, whose wife had died in a nursing home in Chandigarh. The name of the case is Deep Nursing Home versus Manmeet Singh Mattewal. It's a decision of the Supreme Court this year. So in that case, what had happened was that this was the second delivery of the lady. The second delivery of the lady, and the first child was an autistic child. Even in this delivery, when the patient was pregnant for the second time, she had consulted some other doctor. And but for the purpose of delivery, she had approached Dr. Kaveri Mayra of Deep Nursing Home. She went for delivery. It was a normal delivery that had happened. But unfortunately, her uterus did not contract properly. And there was severe bleeding post the delivery. So this is what had happened. Also in this case, unfortunately, the child which was born had died. It was a stillborn child. He did not breathe. He did not cry, did not breathe, and therefore was declared dead. There is a controversy as to whether the lady fell into shock because she was told that the child which is born is dead, and due to which her uterus stopped contracting. Was it because of shock, and whether that amounted to negligence? So in this case, the person, he had, and then the question was whether proper care was provided, whether facilities were there. So immediately after this postpartum hemorrhage had happened, the facility did not have the instruments to provide corrective treatment. In fact, at that time, the only treatment in the entire Tri-City was available only at PGI Chandigarh. So the doctor, once they knew that it was a case of PPH that could not be managed, they sent the lady in an ambulance to PGI Chandigarh, which is in the same city. Now, the question was whether there was any negligence either in the prenatal checkup. The person in this case, who is the husband of the deceased, had alleged that prenatal, that is pre the birth of the baby, there were negligence which was committed by Dr. Kavarjit Kochar. He had filed multiple complaints and there were 5 medical boards, all of which had exonerated the hospital and the doctor. However, when the matter reached the State Consumer Disputes Forum, they found that there was medical negligence, in the sense that uh, certain facilities were not there for antenatal checkup. Similarly, the NCRDC said that this is what the doctor should have done, and antenatal facilities were not there, in the sense various hematological investigations were not done. But that was not even the case of the petitioner, the complainant in this case. So Supreme Court, he was awarded an interim compensation of 10 lakhs, but Supreme Court in an appeal quashed the decision of the NCRDC and SRDC and said that decision is wrong. Why? Because what the petitioner had not alleged, that the NCRDC had inferred. He had not alleged any antenatal negligence, that this is what it is. He had only alleged postnatal negligence, which they found was not there in this case. So Supreme Court reversed, and he has been asked to return the money, 10 lakhs as compensation to the doctor and to the hospital and to the insurance company from whom he had got. Now, in this case, please understand why the doctor succeeded was, A, there was no manipulation of the medical records. There was no overwriting on the medical records, unlike the previous case. Secondly, the doctors had cooperative and they had all the facilities that were required in a nursing home. They had not claimed themselves to be a super specialty. They had not claimed that the doctor did not come at all once things have happened. So they had pediatricians, they had trained gynecologists, they had a referral ambulance, they sent the nurses in the referral ambulance, and everything was done as per the protocol which was there. So there was no violation of the protocol. It was alleged that, blood transfusion had happened late. The question was whether in case of delivery, you are required to keep blood on standby. The answer is no. So and the fact that there were 5 medical boards which had supported the doctor that, there was no negligence, that all went a long way in, the finding that there was no negligence in this case. And therefore, what I would want to ask you is, compare the facts of this case with the previous case. I think there are times when facts speak out for themselves. So in this case, there was nothing, which was showing that, this is a lapse which has been done by the hospital. So standard protocols were followed. So there was no liability. The third case on medical negligence please go ahead, Shivani. Please go ahead with your question.
I'm so sorry for interrupting. I thought that was the end of that. But ma'am, actually, I had a question. So as residents and residents to be, there are times where we're writing our notes, etc. And there may be certain, I mean, it's very basic, but there may be certain times where we may scratch out something and overwrite on it. Does that stand to be like really extensively used against us? Because you were mentioning that there were no, like, does that stand
So
to
in
be
the
really
previous case, one of the doctors, Dr. Priyanka Gupta, if you read that judgment, she was the junior to the gynecologist, Dr. Neha Jain, who was indicted mainly. So the question was that, the corrections had happened for XYZ reason. See, law cannot always be black and white in saying you should not be able to correct it, or, you should use a whitener or discard the pages and then do it. It's but human to err, it's but human to correct. But if you properly document why a correction has been necessitated, Suppose the patient says A in the first place and then says B and then says, no, I'm sure it is about B. You make a correction and then you give an explanation. And then you sign on the correction that why this checking has been made. But if it appears to be so, if those are the kind of corrections, if that is the kind of record which is maintained, it is perfectly fine. But if corrections are made superfluously, after a record was there and then you are correcting without corresponding changes being made at other places just to evade the liability, then things are very clear. So as they say, even for cheating and manipulation, it takes a lot of time. In those cases, in that case, there were contradictions which were there. Apparently in the record which was there, the fact that there was a delay in sharing the record, that itself spoke for it. So for instance, if you have made corrections and you noted it down properly and someone asked for the medical records, you share them promptly with the corrections, whatever it is there, the inference will be less against you. And if you have an explanation, always please understand your written submissions will always be asked. You will always be asked to present your side of the story. So if you're able to give explanation which is good enough, then no liability will be attached in such cases.
Thank you so much. That makes a lot of sense.
Yeah. And in that case, Dr. Priyanka Gupta was not held liable for anything. Okay. So who as a junior had made a lot of notes. So that is one about it. It should not be a cover-up. So please understand that between genuine correction and cover-up, people who are going to examine your cases are part of medical board. So they know what is a genuine correction and what is a cover-up. So that's another thing, right? But I will always suggest that in law also, for instance, we have affidavits. At times we have to correct the page numbers. So we obtain the sign of the patient where a correction is made. So if you have that kind of thing, that patient subsequently indicated this, so therefore this correction is being made. If you make a note in your detailed, your field notes or whatever notes you call it, I think that really helps. Whatever are your internal noting, there is a file that you guys maintain. So if you write down there, I think that will help you save the day. All right, the third case that I was tasked to discuss is a case which has been repeated. It's a case on retinopathy of prematurity. I know you've decided this case because of the amount of compensation that may be awarded in this case. That's case number 3, V. Krishna Kumar versus State. If you have the slides, please go to that. Now, the question in this case is whether it is mandatory for the gynecologist who has helped deliver a premature baby to guide the parents to screen for ROP. What do you think is the answer? See, there is a certain indicator for an ROP. Not in all cases, retinopathy of prematurity is indicated. It is a problem, associated with preterm birth and low birth weight. So there are certain indicators. The question is, are doctors, the gynecologists, the attending pediatricians supposed to inform the parents about screening such cases for ROP? What do you think? Is there a duty? Please understand that medical literature in India is not available with everyone. We are medically illiterate. We just know to use turmeric in case of cold, cough, or maybe tulsi. Beyond the kitchen Ayurveda, I don't think so. We as Indians know much about detailed screening. And we always rely on doctors, and we do not know that what are the indicators. So in this case, what had happened was that there was a preterm child who was born who fell into that category for ROP. Despite being in an ICU for a couple of days, she was, I think, hospitalized for 25 days. No one advised the parents to go for ROP screening. Ultimately, the child did develop ROP in this case, and she was permanently then blind. And then they filed a case of negligence. Supreme Court upheld the findings of negligence and awarded a compensation tuning to 1.8 crores in this case. And this case firmly establishes that duty of care extends to preventing certain diseases if they can be, if they are essentially they could have been prevented. So that duty of care extends not just in treatment but also in prevention of certain diseases. And this case has been affirmed by a lot of other judgments, including Maharaja Agrasen's case, where also similar facts, the child had all the indicators to be screened for ROP, was not screened, then turned blind. The Supreme Court applied the facts of this case and said, yes, it is mandatory. So as a part of protocol now, gynecologists and the treating pediatrician should tell, it is the duty to tell the parents, like you tell the parents ki, please, this is the mandatory vaccination, you have to do it. So please tell if there are certain indicators that these are probable diseases that the child might develop because of the low birth weight or others. Please tell them that these are the things that you have to do, and make a note that you have informed the parents. Whether they do it or not is totally up to them. You don't have to screen for ROP, but you have to guide them that they should get the child screened for ROP. So that's what this case established. And please understand that this is not just on ROP. If there is anything else, I just gave the example of vaccination. Let's say tomorrow there is another disease, which is preventable by way of screening, and there are certain indicators, then I think that gets added to what is the existing duty of the doctor. So whatever is possible to be prevented, and doctor, because there is information asymmetry, only could have known that this is prevented and should be screened, then they have the duty to inform. I think I'll stop here. If there are any questions or concerns, we can take them.
If there are any questions, you may ask them now in the session.
I think everyone is too tired to ask any questions. You've had a long day, seems.
Okay, then.
Ma'am, one small doubt, if I may.
Go ahead.
Ma'am, so in private hospitals,
I'm listening. Go ahead.
like they do have plenty of information, right? Does it have any?
Can you repeat? I don't think so. I was very clear with your comment. I just heard in private hospitals they have. After that, I couldn't hear properly.
Sort of upper hand over the editing documents, the electronically generated data. Ma'am, can you hear me? Put it out and then they give it, right? So all the symptoms that the patient had post-surgery, what has happened. So just typing things out and giving, and just writing things, it doesn't have any difference. So it doesn't have like any superiority, like if the information is printed out.
It's not enough to, as of now, it is not required that the documentation should be electronic. Though there was a push which was made by the NMC regulations, which are now in abeyance, the professional ethic regulations, which spoke that, in 3 years, everyone should be moving towards electronic records, but they have been kept in abeyance. Then, according to the applicable law, medical records for inpatient admissions have to be maintained for 3 years. So it is up to you whether you want them to be handwritten, whether you want them to be digitalized. But if they are handwritten, please ensure that the handwriting is legible. Courts have held against doctors where the notes are there, but nothing is legible. So that's the only request. I mean, irrespective of the format that you record, ensure that they are properly saved in proper custody, not capable of being tempered. And secondly, they are legible.
Thank you, ma'am.
Any other questions? Certain hospitals, because of NABH guidelines, which are voluntary, I mean, if they have NABH certification, are now required to have electronic records. I think that's one of the criterias for NABH accreditation. So just check that. Any other questions, concerns? Any of the case laws that you feel have been improperly decided? There are certain other principles that the courts should have applied in those cases. No. All right, then we'll stop here. Over to you, SIMSOG organizers. Thanks for having me. I hope you've learned something, if not everything, out of these cases. But thanks to the organizers for really bringing out these cases, for curating these cases. I mean, I generally refer to them during my classes on medical law at NLS. But for your team to curate them and bring out the relevant one, I think kudos to the team. I mean, you really did a good job.
Thank you so much, ma'am, for taking your time out of your schedule and to be with us. And this session was incredibly grateful with the depth of your research. It was really good. And we don't often hear, being in a medical background, the legal aspects which were explained with such a clarity. And it gave a whole new perspective for this session, ma'am. We are truly grateful and to have your time and expertise regarding this session. Thank you, ma'am.
All the best.
Thank you for being here. The feedback forms will be sent in the group, and we'll see you tomorrow.